Hi again, and welcome to the second part of the presentation on pre-existing conditions. I divided this topic into two parts to decrease the length of the video. We will continue by looking at cardiovascular disorders during pregnancy. As we discussed when we did adaptation to pregnancy, we realized that major cardiovascular changes during pregnancy that affect women with cardiac disease include your increased intravascular volume, which is needed to support the fetus. There is also a decrease in systemic vascular resistance that contributes to the pooling of blood, especially in the extremities. And then cardiac output also changes. During labor and birth, we realize that cardiac output increases during the first trimester, and after birth, you lose about 500 cc's of blood, which decreases the blood volume and decreases also the cardiac output. And then there are certain intravascular volume changes that are also occur after childbirth, such as the reduction in the dilations of the blood vessels which occurred in the pregnancy state. Preeclampsia complicates approximately 5% to 10% of all pregnancies, and hypertensive disorders of pregnancy are the most common medical complications reported during pregnancy. This is also a significant contributor to maternal and perinatal morbidity as well as deaths. And so it is very important that we screen patients for gestational hypertension, and also if they have pre-existing hypertension, make sure we manage them well. So gestational hypertension is diagnosed after 20 weeks when there is systolic blood pressure greater than 140 and diastolic blood pressure greater than 90 millimeters of mercury. And this should be in a previously normotensive woman. That means that they did not have hypertension prior to the pregnancy. In addition, there should also be no protein in the urine. Development of hypertension and proteinuria in a previously normotensive woman after 20 weeks of gestation is what we call preeclampsia. This can also be diagnosed in the early postpartum period right after birth. In the absence of proteinuria, the development of new onset of hypertension with the new onset of any of the following can also result: thrombocytopenia, renal insufficiency, impaired liver function, pulmonary edema, or cerebral and visual symptoms. There are three classes of preeclampsia, or also known as gestational hypertension. We have mild preeclampsia, and with mild preeclampsia, blood pressure is normally greater than or equal to 140/90, and you should obtain this at 2 different times to make sure that you are getting a good reading to base your diagnosis on. Then you also will see proteinuria, which will be present about 300 milligrams per deciliter for a 24-hour test, and also +1 or greater than +1 on a dipstick. However, there will be no seizures, and the patient is not going to have hyperreflexia, or what we call increased deep tendon reflexes. Signs and symptoms of mild preeclampsia may be mild facial edema, weight gain of about 4.5 pounds per week, and that is going to be what you will see in a patient with mild preeclampsia. Then we have severe preeclampsia, and severe preeclampsia is any gestational hypertension where the blood pressure is greater than or equal to 160/110, and you are going to see about 5 grams of protein in a 24-hour test. And if you do a dipstick with urine, then you are going to see protein that is greater than plus 3 or 3 plus. But the patient is not going to have any seizures, and they will have some hyperreflexia, which means an increase in the deep tendon reflexes. Signs and symptoms of severe preeclampsia include headache, oliguria, which is decreased urine output, blurred vision, and thrombocytopenia, as well as HELP and PE. We will talk about HELP later on in this course. Then we have the eclamptic state, which is eclampsia. Eclampsia means clamping, which means tension. So eclampsia means that there is seizures that are present. And this is classified when the blood pressure is greater than or equal to 110, and there is a lot of protein in the urine. So you see marked protein in the urine, and there is the presence of seizure activity. There is also going to be, of course, hyperreflexia if there is seizures. Signs and symptoms include acute renal failure, severe headache, and possible hemorrhage. So these are the 3 classes of preeclampsia or gestational hypertension. Eclampsia, as I said, means convulsions and is the development of seizures or coma, and it's not attributable to any other causes. So if the patient did not have any seizures prior to the pregnancy and they begin having seizure activity because of gestational hypertension, then we can say that the patient has eclampsia as a result of the hypertension. Chronic hypertension or pre-existing hypertension is diagnosed and treated before the 20th week of gestation. And remember that gestational hypertension is diagnosed after 20 weeks of gestation. And so if the woman had pre-existing hypertension, that means we will find out during the first prenatal visit, which will be normally about like the first trimester, that most patients will show up for their first prenatal visit, and that will be within 12 weeks, so it will be less than the 20 weeks. A woman with chronic hypertension that is controlled can also develop preeclampsia, which will increase the baseline blood pressure, and this is called superimposed preeclampsia. So we have talked about the signs and symptoms of preeclampsia, and these signs and symptoms are only developed during pregnancy. And risk factors for preeclampsia include family history. So if the client's mother had preeclampsia, then they are likely to also have preeclampsia. Multifetal pregnancy, which increases the hormones that support pregnancy. We know that the hormones contribute to the increase in vascular volume and also the dilation of the blood vessels and all that. Then race is also another risk factor that can contribute to preeclampsia, such as if the client is of African American descent. And obesity contributes to a lot of medical conditions, including diabetes and hypertension. If the pregnancy is before 19, which will be like teenage pregnancies, and also if it's after 40 years in older clients, then they also stand the chance of getting preeclampsia. There can also be other pre-existing medical or genetic conditions that predisposes an individual to preeclampsia. But for the most part, family history, multifetal pregnancy, and raised obesity are the major contributing factors. So preeclampsia progresses along a continuum from mild to severe, as we've already looked at the various classes, and is caused by disruptions in placental perfusion and endothelial cell dysfunction. This can also cause placental itching and generalized vasospasm, which will give the seizure activity, and reduce kidney perfusion, which will cause the acute kidney injury. So this is the cascade of how preeclampsia develops into eclampsia. All right. With preeclampsia, the patient can develop what we call the HELP syndrome, and this is hemolysis, which is bleeding, elevated liver enzymes, which will mean that the liver is compromised, and low platelets. Low platelets would predispose the patient to bleeding also, because remember that platelets are responsible for blood clots or for clotting your blood. So if your platelets are low, then you will be predisposed to bleeding. HELP is associated with an increased risk for pulmonary edema and also renal failure. And liver hemorrhage can also occur, which will lead to liver failure. And in addition to that, the patient can develop what we call DIC. This is disseminated intravascular coagulation, where there is bleeding and blood clotting at the same time. And this is a potentially dangerous situation if a patient develops DIC, because it can lead to death. There can also be placenta abruption, which is the separation of the placenta from the uterine wall, and that can cause bleeding, which will compromise the fetus and cause distress. The patient can also experience acute respiratory distress as a result of HELP, and sepsis can ensue from the bleeding that is going on, and sepsis is just an infection or systemic infection in the bloodstream. If clotting occurs in the brain, then a stroke can result from that. So if there is coagulations and then the patient is also bleeding, if there is hemorrhage in the brain, or if there is a thrombus that breaks away and then goes into any of the tiny arteries in the brain, then that can also cause a stroke. With all this being said, the end result is that the mother or the fetus can die as a result of these complications. And this is why we have to really mitigate the effects of preeclampsia. So care management for preeclampsia include identifying and preventing it. And we identify it through physical examination. So with physical examinations, we are going to see dependent or pitting edema. We are going to see an increase in deep tendon reflexes and clonus. Clonus is a test which is done in the feet, and when you when you flex the feet, you will see that it will kind of go in a tick-toe kind of movement. And so when you see that, then you know that there is preeclampsia going on. Lab tests that are done are mainly urinalysis, and this will contain protein or will have some protein in it. So this is an example of pitting edema, and pitting edema can be classified as either +1, 2, 3, depending on the severity. So this is just an example of how you can test for pitting edema. So A will probably be a +1, B will be a +2, C will be a +3, and D will be greater than +3. When a client has mild gestational hypertension or mild preeclampsia, we can basically manage it with diet, which will be a decrease in sodium intake, and also activity restriction to prevent a hypertensive episode. But with activity restrictions, you have to modify it to the client's needs. You will also monitor the mother and the fetus regularly to ensure that the fetus is developing well and to limit the complications of preeclampsia. When the gestational hypertension is severe or the patient has severe preeclampsia, then they have a greater risk for pregnancy complications. So we will do all the monitoring that we talked about and then see if there are any complications that may be developing and then try to resolve those. In the intrapartum period, normally to prevent them from having preterm labor, we will put them on magnesium sulfate. Note that magnesium sulfate is going to relax the muscles and reduce seizure activity. So if your patient is put on magnesium sulfate, you have to assess for DTRs and make sure that they are not absent, because that can be an indication of magnesium toxicity. If preeclampsia is not well controlled or it develops into eclampsia, then there is the need for immediate admission and care in a hospital setting. So the nursing action will be to implement seizure precautions, and part of the seizure precaution demands that the nurse will pad all the surface areas of the bed to prevent injury in case a seizure occurs. And also during a convulsion, make sure that you are not restraining the patient. Make sure that the bed is free from any cords, and make sure that the patient is seizing unimpeded, which means that you cannot hold the patient down, you cannot put anything in their mouth or try to hold the head or anything. Just let them seize, and then after the seizure you can turn them to their side and do oxygen therapy, IV therapy, and everything else that is indicated. Okay. The only way we can prevent eclampsia is to initiate prenatal care as early as possible with the management of preeclampsia using medications. So we've already talked about chronic hypertension, and for the sake of time, I'm not going to go over this slide again. So management of chronic hypertension include the use of antihypertensive drugs. Now, some of them can be found in milk, such as methyl-dopa or hydralazine. Management of chronic hypertension include the use of antihypertensives. Some of the antihypertensives on the market can be found in breast milk, and so that will be detrimental to the fetus. And so the approved medications that are used during pregnancy are methyl-dopa or hydralazine, and these are the choices for women who need medication for the control of their hypertension, and especially if they are wanting to breastfeed. Short-term studies have not found any adverse effects on infants of these mothers if they use methyl-dopa or hydralazine. So if preeclampsia is not treated, then the patient will be at an increased risk for a miscarriage, preterm labor, and also for intrauterine growth restriction. The incidence of congenital heart lesions is also increased in children of mothers with congenital heart disease. All right. Now let's talk about some cardiovascular disorders that that can impact pregnancy. And you don't really need to know all these, but these are important because you can be tested by NCLEX on some of these. But these are not exemplars in this course. Atrial septal defect is a defect in the wall between the left side of the heart and the right side of the heart. And most of the time that allows for cross-contamination of oxygenated and deoxygenated blood. The same thing happens with ventricular septal defect. And with tetralogy of Fallot, it's a cascade of conditions that are present, and these include the atrial septal defect, the ventricular septal defect, the coarctation of the aorta. And when all these are present, then the patient or the fetus has tetralogy of Fallot, and you will see that children who have this condition are easily out of breath and they squat a lot to catch their breath. So those are some of the symptoms that you see. You also have some acquired cardiac disease, which is like the mitral valve prolapse and mitral valve stenosis and aortic stenosis that would decrease cardiac output and perfusion, and so you see the same symptoms that you see in a patient that has impaired perfusion and oxygenation. There are also ischemic heart disease that can occur in the mother, and that will put the pregnancy at a risk. So one of them is the myocardial infarction, which is a heart attack. Other cardiac disease and conditions are persistent pulmonary hypertension, which can occur as a result of heart failure, and then peripartum cardiomyopathy, which is the enlargement of the heart muscle as a result of pregnancy. So all these are some of the conditions that you can see in a pregnant woman. Heart transplantation is also another thing that can affect pregnancy. For example, if you have a client who has had a heart transplant, there are increasing numbers of heart recipients who are successfully completing pregnancies, but think about the stress that pregnancy puts on the cardiac system, and so they may be more than likely to experience some complications related to the circulatory system. If a woman is wanting to have a baby after heart transplantation, then the woman should be assessed for quality of ventricular function and potential rejection of the transplant before pregnancy is planned. And then conception should be postponed for at least a year after a heart transplant to allow for successful pregnancy. The general care for a client who has cardiovascular problems in the antepartum period focuses on minimizing the stress on the heart. And so you are going to find ways to decrease the blood pressure through medication and also be able to limit the effects of pre-eclampsia developing into eclampsia and causing seizures. Normally, the woman is placed on bed rest, and as I said, bed rest should be modified because the pregnant woman also has a risk of developing DVTs. So you don't want to tie them to the bed by restricting their activity. So they can actually do certain things whilst they are on bed rest. They just cannot do any heavy work. Nutrition counseling will include reducing the amount of fat in diet and also decreasing the amount of salt to moderate salt intake. And then cardiac medications, as we talked about, methyl-dopa and hydralazine, as indicated. There is also anticoagulant therapy that can go along with that. And heparin is a drug that is commonly used because it does not cross the placenta. And so to decrease the risk of DVTs and other cardiac problems, we can also use heparin as part of the anticoagulant therapy. And then we also will focus on promoting or preventing the onset of an infection by using prophylactic antibiotics. In the postpartum period, we will monitor for cardiac decompensation, which can lead into hypovolemic shock and resuscitate the patient with IV fluids. Okay. Other medical disorders in pregnancy include anemia, and there are various forms of anemia, including iron deficiency and folic acid deficiency. If the patient has a history of thalassemia or sickle cell disease, then we also have to account for that. But most of the time, anemia is caused as a result of pica. Remember, we talked about pica, the craving for non-food items, which will mean that the client is more nourished, and also sometimes can be caused by folic acid deficiency. So we will have to educate clients that are at childbearing age to take folic acid supplements, because folic acids also contribute to proper fetal development, and deficiencies may cause neural tube defects. So we want to be able to educate the client to increase their folic acid intake. In addition to the cardiovascular disease, there can also be pulmonary disorders that affect pregnancy, because these are going to increase the drive for oxygen and reduce the amount of oxygen in circulation, which will decrease the amount of oxygen that is supplied to the infant. And so there may be exacerbations and remissions with asthma, and then the airways may become hyperactive, because remember that we said that there are changes in the respiratory system that will come about as a result of pregnancy. And then pregnancies cannot be predicted whether they are going to be effective or not, because the complications of asthma may cause a fetal demise if supply of oxygen is cut for a long period of time. And mothers with asthma also have a high risk for postpartum hemorrhage. Other conditions such as cystic fibrosis are part of the pulmonary disorders, which can affect the mother, and also this can affect infants as well, because infants of mothers with cystic fibrosis will be carriers of the gene, and some of them will also have the disease. And so we will have to prepare for any eventualities that these clients have cystic fibrosis. With severe disease, pregnancy is often complicated by chronic hypoxia and frequent pulmonary infections, which means that the amount of oxygen to the fetus is going to be reduced, which will cause a decrease in the growth of the fetus. And so this is called intrauterine growth restriction, and this may predispose the patient or the mother for preterm labor. Also, exocrine glands, which may produce excessive viscous secretions in the throat, can also impair breathing, and there may be problems with respirations as well as digestion that will occur with the patient that has cystic fibrosis. Other medical disorders that may be pre-existing include integumentary disorders that are induced by pregnancy. And so we are going to talked about most of this when we did the physiological adaptations, and so I'm not going to spend time to talk about this again. Okay. Now let's look at some neurologic disorders when present that will complicate pregnancies. Epilepsy is one of the major CNS disease which can complicate pregnancy. So with epilepsy, there is usually the non-compliance of taking medications by patients. So failure to take medications is a common factor that will result in the seizure activity related to epilepsy. The patient should therefore receive preconceptual counseling and at risk, and they should know that they will be at risk for congenital anomalies if the mother is also taking anticonvulsants. So on the other hand, if mothers do not take the medications, then they are going to be at risk for seizures, and that can cause the termination of the pregnancy. And if they take the medications also, these medications are teratogenic and they may cause birth defects in the fetus. And so mothers will have to receive counseling to determine if they can successfully have a pregnancy or carry a pregnancy to term. Multiple sclerosis is a disease of the muscle which causes muscle degeneration, and this can also cause a potential complication for pregnancies. And most of the time, if a patient has multiple sclerosis, then we are going to put them on bed rest and use steroids to treat acute exacerbations to help them carry the pregnancy to term. There is also what is called Bell palsy, which is an acute facial paralysis that can impair pregnancy because this can cause an impairment in the respiration. Autoimmune disorders are also disorders that affect the immune system, and this can compromise pregnancies. And one example is systemic lupus erythematosus. Autoimmune antibody production affects skin, joints, kidneys, lungs, central nervous system, liver, and other body organs. And immunosuppressive medications are not recommended during pregnancy because they predispose the pregnant client to infections, and if any intrauterine infection occurs, then the pregnancy is going to be terminated or end up in a stillbirth, which will cause fetal demise, and so we don't want to use that. On the other hand, efforts are aimed at just reducing the risk for infection and preventing fetal demise. Another autoimmune disorder that can affect pregnancy is myasthenia gravis, and this is an autoimmune motor muscle disorder, and it causes muscle weakness in the eyes, face, neck, limbs, and respiratory muscles. So just remember that if your respiratory muscles are compromised, then you will not be able to have adequate ventilation and perfusion, and so that is going to cause a limited growth of the fetus, and the fetus is going to be in distress. So women with myasthenia gravis usually tolerate labor very well, but they can have complications related to the respiratory system, and so they may require forceps or vacuum delivery if any of these complications occur. Then one other issue that complicates pregnancies, especially in rural areas, is substance abuse. The continual use of substances despite related problems in physical, social, or interpersonal areas is what is known as substance abuse. And this can be diagnosed if the mother is using any prescribed or illicit drugs that they don't have to be using. Okay, so it can be an addictive problem to, say, pain medications or to street drugs. There can be a dual diagnosis if the substance abuse is present plus another psychiatric disorder that predisposes them. So, for example, if you have a pregnant mother that is bipolar and they are also using street drugs, then they have a dual diagnosis of the psychiatric disorder in addition to the substance abuse. And this may have damaging effects on the fetus. For example, as we talked about earlier in the previous presentations, I said that if the patient is addicted to pain medications, such as if they are using hydrocodone or any opioids, then the fetus will be born dependent on the opioid and they are going to have withdrawal symptoms. All right. There are many barriers to the treatment of substance abuse in pregnant women because women will not come forth and tell you because of the fear of losing custody of a child or even for the fear of criminal prosecution. But you as the nurse has a mandate to report if there is any signs of substance abuse, especially illicit or street drugs, because we have to protect the child. There is less than 10% of pregnant women who receive treatment for substance abuse, although it is very prevalent. And so substance abuse treatment programs do not address issues affecting pregnant women because most of the rehab centers are not willing to admit pregnant women into their programs. And there is a long waiting list and lack of health insurance which present further barriers for treatment of substance abuse in pregnancy. Care and management should include drug testing, and so you are going to screen the pregnant mother at the first prenatal visit and you are going to tell them about what you are going to be screening for and obtain consent to do all that. With the initial care, you are going to try to use counseling depending on the severity of the problem. And if the problem is very severe, then they can go into a recovery program and use methadone to maintain their adherence to staying clean. And also they will have follow-up visits every now and then to make sure that they are not still using. If a mother is identified as using street drugs, then breastfeeding is definitely contraindicated because amphetamines, alcohol, cocaine, heroin, and marijuana will all be in the breast milk, and so if they feed their child, that child is going to suffer from the effects and be addicted to these drugs. So you encourage them not to breastfeed. Also, substance abusers find it difficult to care for, are very difficult to care for, particularly during the intrapartum and postpartum period, because for example, the use of cocaine can cause preterm labor, and if the fetus is not well developed or has not reached viability, then it is going to be a loss, and also they are at an increased risk for hemorrhage. Before discharging the client who has a history of substance abuse, you will have to assess the home situation and see if the home is a safe environment for both the mother and also the child. And then you have to note if there is someone available to meet the infant's needs if the mother is unable. So do they have a partner? Do they have family members that are willing to be actively involved with the mother before you discharge them? If the infant's well-being is questionable, then the case will be referred to the Child Protective Services, and this is true because you want to protect the infant and prevent sudden infant death syndrome from occurring. All right, so I have these questions on the slide for you to kind of see if you are understanding these concepts. So decide on your answers by reading the textbooks, and then if you have any question, just email me. Once again, thank you for listening to this presentation. I had to speed up a little bit to make the video a little bit shorter, and so if you have any questions, you can always email me or ask your questions when we meet in class and engage in the in-class activities. Take care.